Welcome back to the next session. The first question we are going to discuss here is ingrowing toenail. Okay, what is that? Ingrowing toenail. Sir, what do you mean by this ingrowing toenail? Okay, suppose I take the big toe of the foot. I cannot show you foot, that's why I am showing you thumb here. Okay, suppose there is big toe of the foot. Now this is your nail plate. Okay, the surrounding skin which you are going to see here, this has to be your periungual skin, which is around the nail, has to be called as periungual skin. Now if at all the nail plate it is growing into the surrounding periungual skin, then I have to call it as a ingrowing toenail. Okay, it is nothing but the nail plate. Nail plate means nothing but your nail. Okay, this is growing into this surrounding skin. Okay, that is when you have to call it as a ingrowing toenail. Write it down. It is nothing but the nail plate which is growing into periungual skin. Okay, suppose this is your nail plate, you can call, and this is your big toe. Okay, now this is growing into the surrounding skin also. Okay, when it is growing into the skin, surrounding periungual skin, that is when I have to call it as an ingrowing toenail. Now usually seen in young individuals, most commonly it is seen in the big toe. Okay, big toe of the foot. Now what are all the clinical features with which the patient is going to present to us? Sir, it is growing into the periungual skin. Sir, then what is the problem? Due to this growth into the skin, what happens is there can be inflammation, there can be infection. Okay, whenever this nail is growing into the skin, there is always an entity of inflammation or infection. Write it down. It can lead to inflammation there, or it can lead to infection. Now can you tell me what happens if there is inflammation over there? Okay, it is going to be swollen, it is going to be red, and it is going to have a pain. So whenever there is inflammation, you can see redness over there, and the area is going to be swollen, and the patient complains of pain in that region. Okay, these are all the features with which the patient is going to present to us. Investigations and all you need not need. Why? Because it is on clinical examination itself you can diagnose this. Okay, diagnosis, no investigations are required, just clinical examination is enough to diagnose this case. Now how to treat this case? I told you there will be inflammation in this condition. This inflammation can be a mild one or can be a severe one. If at all it is a mild inflammation, what I have to do is I have to keep this in a foot bath. Okay, I have to insert this in a soapy water. Okay, soapy foot bath. Okay, in a soapy water I have to keep my foot for some time. After that, and I have to let the foot dry. Okay, this soapy foot bath, along with that I have to give antiseptics, and I have to give anti-inflammatory drugs. Okay, as it is an inflammatory condition, I should give anti-inflammatory drugs also. But I'm not giving them orally, I am giving it topically itself. Means I have to give it as maybe as tinctures, maybe as gels, or maybe as creams. I have to give. Okay. If at all it is not a mild case, it is somewhat a severe case. Inflammation is severe, pus formation is also there. All these things are there. Okay. Then I have to go for surgery. Okay. What should I do? I have to remove that involved part. Okay. Remove involved nail. Okay, that part which is growing into the skin, that involved nail part, I am going to remove. This is, you should know about ingrown, not a very big topic, just a very small topic only. Okay. Coming to the next one. Next question is about prophylaxis for deep vein thrombosis. I am going to discuss this in the immediate next module. I am going to discuss this. Why? Because there is a lot of entities. Before going to prophylaxis of DVT, there are a lot of entities to be discussed in DVT. That is why in the immediate next module I will discuss about it. Coming to the next question is about basal cell cancer. We have already gone through malignant melanoma, which is one skin cancer, and the other we are studying here, it is basal cell cancer, and the other is squamous cell cancer. These are the three important skin cancers: squamous cell cancer, basal cell cancer, and malignant melanoma. Okay, and we have already gone through malignant melanoma. Now we are dealing with basal cell cancer. Coming to basal cell cancer, it is a very slow growing tumor only, very slow growing tumor. Still it is a malignant tumor. Please remember, basal cell cancer is a malignant tumor, and much more important point than this is, in general, malignant tumors always have a tendency to metastasize, but there is one exception to that. Malignant tumor without any distant metastasis is your basal cell cancer. Very important. Malignant tumor without any distant metastasis, may be lymphatic or may be hematogenous. There is no lymphatic metastasis, there is no spread through hematogenous route also. It is basal cell cancer. It only has it is locally invasive, I accept, but it does not have any metastatic potential to the distant regions. Write it down. It is malignant only, but it is locally invasive only. But there is no metastasis. No metastasis. Either lymphatic route also no metastasis is there, and even hematogenous also no metastasis is there for basal cell cancer. Okay. A malignant tumor without any metastasis is your basal cell cancer. It is locally invasive, but now, sir, where it is going to arise from? I am using the term basal cell cancer. Why I am using the word basal means it is going to arise from the basal epidermis. Okay, write it down. Pluripotent epithelial cells. Epithelial cells which are present in the basal epidermis. As it is going to arise from the cells which are present within the basal epidermis, I am calling it as a basal cell cancer. Now, what are all the risk factors for basal cell cancer? Ultraviolet radiation, very important risk factor. Ultraviolet radiation, and even in white skinned individuals are at risk of developing this basal cell cancer. And the same things I have already told you in malignant melanoma: ultraviolet radiation and white skinned individual. These are risk factors for malignant melanoma, and the same thing for basal cell cancer also. Coming to macroscopy, on gross what we can see, there are many variants of basal cell cancer, but the important ones are nodular variety, nodulocystic, means there should be nodule. Okay, even almost 90% cases of basal cell cancer falls between this nodular and nodulocystic. Sorry. Coming to microscopy. Under microscopy, just a second, if I have any images I will show you. Okay, microscopy is going to show me ovoid cells, basaloid cells or ovoid cells which are present as nests. Means what? Group of cells together, group of cells together, group of cells together, that is called as tumor nests. Okay, ovoid cells in nests with a single palisading layer, important, with a single palisading layer. Okay, this is just a diagram I have drawn schematically. You already know I am not good at drawing. Okay, now what is this? This has to be your epidermis. Now here what you can see is, you can see all these cells here. When you look at all the cells which are present over here, you can see these ovoid cells. Okay, ovoid cells are present as tumor nests. Okay, a group of cells here, a group of cells here, a group of cells here, they are going to present as a tumor nests. Okay, group of cells together, group of cells. Okay, and within this also, if you carefully observe, I can see a single layer which is present like this. A single layer which is present like this, means a palisading layer, a single layer. That is why I have written ovoid cells which are present in the nest along with a single layer of palisading cells also. You can see this is the microscopy of basal cell cancer. Now okay, right, here also what you can see here, yes, you can see the nodule also. This is your basal cell cancer, and here also you can see this. This is also your basal cell cancer. So one thing I want to tell you over here is, sometimes the basal cell cancer is going to present to us like a ulcer in the region, around in this region you can see, that is called as your rodent ulcer. Okay, rodent ulcer is a feature of basal cell cancer and this ulcer is going to have rolled out edges of an ulcer is a feature of basal cell cancer. Now coming to the prognosis of a case of basal cell cancer, I can divide the basal cell cancer into high risk and low risk. High risk basal cell cancer and a low risk basal cell cancer. Sir, what happens in high risk? Sir, define the word high risk. High risk is something, if at all the BCC, basal cell cancer, on local invasion, it can involve the cranium part. Then I have to consider it as a high risk. Suppose if it is near the eyes, it can involve the cranium. If it locally invades, it can involve the cranium. Okay. If it is near the nose, if it locally invades, it can involve the cranium. Okay. In all these places which has the access to the cranium, then I have to consider it as a high risk basal cell cancer, where direct invasion gives access to cranium. For example, maybe near the eyes, maybe near the ears, maybe near the nose. Okay, if at all it is going to occur near these structures, then there is always a accessibility to enter into the cranium also. That is why I am considering them as high risk basal cell cancers. Next, coming to treatment of a case of basal cell cancer. Treatment is very simple. It is just a wide local excision. Wide excision, obviously with some 1 centimeter margin. So the preferred treatment for basal cell cancer is always wide excision. With the 1 centimeter margin I have to take, and I have to excise that. And we have other options also. Some medical treatment is also available. 5-fluorouracil is one drug we can use. Imiquimod is one drug we can use. Vismodegib is other drug. These are some of the drugs which are used as medical treatment for a somewhat a superficial basal cell cancers may be there. For those things we can use these. Okay. Now, the treatment of a basal cell cancer is not complete without mentioning this topic, Mohs microscopic surgery. Now, what I have told you in the beginning is I have to do a wide excision with a 1 centimeter margin. So suppose this is the tumor. I am taking a 1 centimeter as a margin and I am removing that entire area. But the problem which can arise with this operation is, just I am assuming the tumor and I am going to remove on the basis of the tumor 1 centimeter margin. But I cannot perfectly know whether I am clearing the entire involved metastatic part. I mean entire involved tumor part. Okay. What we are doing in Mohs microscopic excision means it is done under microscopic evaluation. Means whenever you are doing a surgery under microscopic evaluation, you are doing excision, you can clearly say how much part the tumor is involved and you can remove that much part. Okay, so the recurrence rate is going to reduce when you are going to perform a Mohs microscopic excision. Okay, when to opt for Mohs microscopic excision? If at all there is high risk histology, on histology there is high risk histology you can see, then you have to opt Mohs. Otherwise, if it is a recurrent one, if it is already a recurrent one, it is always better to go for this. Why? Because you can, under the microscope, you can see until what layer you have to remove, layer by layer. First thing is, you excise some part. Under the microscope, if the tumor you can see, again you are going to remove further part. Until you can get the normal tissue, you are gonna remove layer by layer, you are going to remove. So, that is why Mohs microscopic excision will have a less recurrence rate. Okay. And then the other indication is if at all it is near any vital structure, I would better go for a mouse microscopic excision. Okay, this is the treatment part. Okay, under treatment we have discussed wide local excision with 1 centimeter margin and some drugs like 5-fluorouracil, imiquimod and vismodegib. Now, mouse microscopic excision, obviously it is excision under microscopic view also is there. Layer by layer we are going to cut off and we are visualizing under the microscope till the normal tissue is found, we are going to remove. Okay, useful especially if it is a recurrent one or especially if it is a high risk histology or you can if it is near any vital structure. Now coming to the next question is about an electrolyte imbalance actually, that is hypokalemia. I cannot say purely it is a surgical entity, but resuscitation with resuscitation of body fluids in case comes under surgery, I think so. That is why they have asked this. Now, can you tell me the normal potassium levels in the body? The normal levels of potassium will be somewhere between 3.5 milliequivalents to 5.5 milliequivalents. Okay, 3.5 to not milliequivalents, sorry, millimoles per liter. 3.5 to 5.5, anything less than that is hypo, anything more than that has to be hyperkalemia. Now, what are all the, after looking at the normal values, now let us look at the etiology. Looking at the etiology of what are all the causes which lead to hypokalemia. First thing is, whenever there is a reduced intake through the diet itself, okay, reduced intake is there, then you can get this hypokalemia. Or whenever there is an entity called tissue redistribution. Sir, when will this tissue redistribution occur? When will the potassium get distributed to the tissues? Means during insulin therapy this can occur. So insulin therapy is a very important risk factor, is a very important cause for hypokalemia. Very important this is. Why? Because whenever you are giving, suppose there is a patient of diabetic ketoacidosis, you are giving insulin to the patient, you have to monitor the potassium levels. It is very important to monitor the potassium levels in the patient. Why? Because insulin therapy is something which can always cause hypokalemia. Okay, if at all there can be increase in the loss of potassium also. Sir, how this can occur? Suppose the patient has a diarrhea, or suppose the patient may have vomiting, or the patient may have got any fistula. Okay, maybe the loss may be due to diarrhea, it can be due to vomiting, it can be due to fistula. If you remember, in enterocutaneous fistula, I have already told you, the more proximal the fistula is, the more electrolyte imbalance it is going to have. Okay, I have already told you in an enterocutaneous fistula, the more proximal the fistula is, the more electrolyte balance it is going to have. Next, sometimes even the usage of diuretics, you already know, potassium sparing diuretics, they will not cause hypokalemia, but loop diuretics and thiazide diuretics, they causes hypokalemia. Okay, except potassium sparing diuretics, other diuretics usually they can cause hypokalemia. Okay, now what are all the symptoms with which the patient is going to present to us? Symptoms, some vague symptoms, anorexia may be there, nausea may be there. Okay, now coming to the important symptoms, it is muscle weakness. Muscle weakness is very important symptom of a hypokalemia. Whenever there is hypokalemia, there is muscle weakness. If at all there is weakness within the musculature of the bowel wall, what will it lead to? It lead to a condition called paralytic ileus. Okay. What is paralytic ileus? If at all there is problem in the contraction of the smooth muscle of the gastrointestinal tract, it will cause paralytic ileus. Even in hypokalemia, there is weakness of the muscles also. Sir, why there is weakness of the muscles? Why? Because of hypokalemia. Hypokalemia, always remember, it causes muscle weakness. It can cause paralytic ileus. Anorexia and nausea, they are vague symptoms, you can remember. Now, sir, what are all the ECG findings? ECG findings in a case of hypokalemia. Okay, ECG findings in a case of hypokalemia. It is somewhat difficult only, but I try to simplify this as much as I can. Okay, just remember these things. Do not go into much more depth of ECG changes and all. Just try to remember what I am going to discuss. Suppose I will draw you a normal ECG. Okay, please don't worry, I am somewhat poor at drawing. This is your P wave, and then comes your QRS complex, and then comes your T wave. Okay, just I have tried to draw normal ECG. Now, if at all there is any other wave, okay, again this again, after this the P wave comes and the QRS and the T wave, this cycle is going to repeat. Okay, one ECG to the next part. Okay, now if I take this, suppose between these two P waves, between the T wave and the P wave, if at all by chance I can see some other wave here, by chance on ECG I find some other wave, I have to call it as a U wave. Okay, and one more thing I want to mention it now itself is, any wave which is seen just after QRS has to be your T wave. Okay, so this has to be your actual T wave. Why? Because it is seen immediate next to QRS complex. So after that, the new wave you are seeing here, this has to be your U wave, and this is your normal P wave of the next cycle. Okay, this is your P wave. Now, what we are going to see on ECG in this case is, we can see presence of a U wave, presence of a U wave on ECG can be seen. Sometimes what happens is, after this, the T wave which is there, now it is going to become flat. The T wave which is there, it can become flat. The moment T wave becomes flat and there is appearance of a U wave, what we will be mistaken is, we thought that there is increased gap between the QRS complex and the T wave. We mistaken U wave as T wave. Okay, when we mistaken U wave as T wave, what happens? We feel that there is QT prolongation. This QT prolongation, we feel that there is QT prolongation, but it is not actually a QT prolongation. There is flattening of the T wave. There is no T wave actually. Due to this flat T wave, the U wave is already present. This U wave, we may confuse it as a T wave. So we assume that there is QT prolongation. That is why I am calling this as apparent QT prolongation. Actually, there is QT is not prolonged, but due to flattening of T wave and presence of U wave, we may assume that there is QT prolongation. That is why I am writing apparent QT prolongation can be seen. Now, even after this, I have already told you, initially there is U wave, presence of U wave. After that, what happens? The T wave which is there, it is going to get flattened. Now, even after that, what happens is, the T wave which has got flattened, Now it will get into a inversed state. Okay. T wave inversion, you can see T wave inversion plus U wave obviously is there. Now even further stages, what can even happen is this T wave can even form T wave which is formed like an inversion. Now it can even form like a roller coaster T wave, very important. Okay, it can even form something like this roller coaster T wave plus U wave as usually. This is also. So what are all the ECG changes? First and foremost is presence of U wave. Presence of U wave is a feature of hypokalemia. Okay, we can see both the T wave and also the U wave. We can see flattening of the T wave plus U wave. We can see T wave which has been inverted plus U wave, or we can see a roller coaster T wave inversion plus U wave. Any of these things can be seen in case of hypokalemia. These are all the sequentially I have told you so that it will be easy for you to remember. Now on top of this you can see wide QRS complexes, and even due to hypokalemia there can always be a risk of arrhythmias is also there. Okay, now coming to management of a case of hypokalemia, most important is treat the cause. Suppose if it is due to diarrhea, or if it is due to warm things. Okay, if it is due to diuretics, you have to stop them. If it is due to insulin therapy, you have to stop the insulin therapy. All these things based on the cause you have to treat. And next thing is I have to give potassium supplementation to the patient. Potassium supplementation has to be given to the patient. Maybe initially I can try some dietary, maybe milk I can give. Fresh juices like banana juice and all those things, they can contain potassium, and even coconut water is also rich in potassium. We can give coconut water also to the patient. Now I can give syrup, potassium chloride syrup. Potassium chloride syrup can also be given. Sir, these are all the things you are telling, but that's okay. But what if the patient is in such a condition, he is unable to take the feeds orally? What to do then? Then there is no option for me to give oral potassium chloride. Then I have to go for intravenous potassium chloride. Okay, intravenous potassium chloride I have to give. If the patient is unable to take orally, then I have to go for intravenous potassium chloride. One thing I want to mention is, if at all I am giving potassium chloride through the peripheral venous route. Okay, if at all I am giving peripheral intravenously into the peripheral veins, then I should make sure that I am giving potassium at a rate which is less than 10 milliequivalents per hour. By chance, if I am giving in a central intravenous route, then I should not give more than 20 milliequivalents in an hour. Make sure you are doing this. This is about the treatment of a case of hypokalemia. Okay, thank you for watching.